Behind every stomach ache lies a different experience. This time, we will go to Europe and Egypt to explore 4 stories of stomach pain. None of them have stomach problems. Can you guess what are the causes of their illness? In Romania, a 67-year-old man was admitted to the emergency room for intense epigastric pain. He also presented with nausea and vomiting in the last 5 days. He had been diagnosed with diabetes and hypertension 10 years ago. Chronic treatment was conducted with lisinopril 5 mg per day, metformin 1000 mg per day, and lixisenatide of 10 mg per day. The GLP-1 receptor agonist treatment was started 3 months ago. Blood tests show elevated pancreatic enzyme lipase level of 665 units per liter and high amyloidemia levels of 240 units per deciliter. CT confirmed the peripancreatic fatty tissue and pancreatic edema, but no anatomical abnormalities or gallbladder stones were found. The case was interpreted as acute pancreatitis. After the exclusion of all the other possible causes for acute pancreatitis, the cause of pancreatitis was related to the GLP-1 receptor agonist. The lixisenatide treatment was interrupted. After 24 hours, lipase serum levels started to decrease. Clinical status progressively improved, with no pain or vomiting from the second day. At 1 month follow-up, the patient had normal blood sugar values, normal biological status, and no clinical symptoms. In Rome, Italy, a 25-year-old male presented to the emergency department with epigastric pain. His hemoglobin levels, white blood cell count, ALT, GGT, and bilirubin levels were normal, with amylase level being 601 international units per liter and lipase level as 986 international units per liter. He performed an abdominal ultrasound that revealed a normal biliary system and gallbladder, but the presence of a diffuse enlargement of the pancreatic gland. The diagnosis was acute pancreatitis. 2 months later, the patient returned with the same symptoms of epigastric abdominal pain and nausea, and it was yet again admitted to the emergency department. The blood exams confirmed the diagnosis of acute pancreatitis with normal liver test and bilirubin results. Abdominal contrast enhanced CT revealed the presence of a diffusely edematous pancreas. 4 months later, he developed a new bout of abdominal pain and nausea and was yet hospitalized again. All 3 acute pancreatitic episodes were considered idiopathic, as alcoholic, biliary, autoimmune, genetic, and drug-related etiologies were excluded. Yet, after further interviewing the patient, he reviewed a daily use of cannabis for recreational purposes. The patient stopped consuming cannabis, and no further episodes of acute pancreatitis occurred during a 12-month follow-up. Again, in Rome, Italy, a 38-year-old woman at 27 weeks of gestation was admitted to the Policlinico Umberto Hospital in Rome. The patient reported a 2-week history of recurrent epigastric abdominal pain associated with episodes of nausea and vomiting. Blood tests show a total bilirubin of 99.2 millimoles per liter and amylase of 687 units per liter, with lipase level being 678 units per liter. Abdominal ultrasound revealed a markedly dilated gallbladder, dilated biliary tract, and enlargement of the head of the pancreas. They also found a 28mm mass that was located in the pancreatic uncinate process, compressing both the pancreatic duct and the biliary tract. MRI was then performed, which revealed a 4 cm mass localized in the head of the pancreas. The histological report of the biopsy suggestive of intraductal carcinoma of the pancreas. Because of worsening of the maternal condition, an immediate C-section was mandatory. A live baby girl weighing 1,095 grams was delivered. Chest, abdomen, and pelvic CT was performed 5 days after the delivery. It confirmed the presence of an infiltrating 5 cm mass in the head of the pancreas, with metastasis to the liver, lung, and lymph nodes. Now moving to Egypt. In Mansoura University, Egypt, a 34-year-old male patient with a history of hypertension was presented with epigastric pain for 3 months. Abdominal CT revealed a well-defined, thick-walled, marginally enhanced cystic lesion in the body of the pancreas, measuring 7 cm by 4.5 cm. Blood tests completed the blood picture, with liver function test and serum amylase within normal range. Enzyme-linked immunoabsorbance assay, ELISA, tests for echinococcal antigens were positive. He was treated by surgery and oral albendazole therapy. Now, looking at the anatomy, the pancreas sits deep in the retroperitoneum. It is surrounded by the stomach, intestines, liver, and major blood vessels. The anatomical location of the pancreas makes pancreatic cancer uniquely difficult to detect early. Early-stage pancreatic cancer is typically a silent disease that causes no noticeable symptoms. Because of the location of the pancreas, it is easily obstructed from screening, making this a limitation to the standard trans-abdominal ultrasound. The pancreas sits deep in the retroperitoneum, surrounded by the stomach, intestines, liver, and major blood vessels. It is virtually impossible to evaluate with a standard physical exam. Therefore, cross-sectional imaging like CT and MRI are the primary diagnostic tools. In this video, we explored 4 cases of epigastric pain across Europe and Egypt. They initially thought it was a stomach issue, but it turned out to be a pancreatic-related disease, such as pancreatitis, pancreatic cancer, and the large pancreatic cyst.